Alrighty. Hello, everyone, and welcome back to PS Platypus. Today, we're going to be having a look at some pharmacology, focusing on all the drugs you have to know for your gastrointestinal conditions. So we're going to be focusing on medications that are going to be used to treat constipation, treat diarrhea, vomiting, or nausea, as well as reflux and ulcer disease. The main thing that I want you to keep in mind here is that this is a very much high-yield summary of everything you have to know, more so for your exams. So it's not going to contain each and every single point you might cover in your university lectures. But if there are any additional details or things you have to know, I have included them in the speaker notes for you to have a look at. The majority of those points, however, won't be as relevant for you in this semester or at this point in time. They'll become more relevant as you go along and learn more about renal physiology, and then later on about Parkinson's management and things like that. So just keep that in mind. I've put them into the slides in the speaker notes, but they're not included in the main slide set. All right, so in terms of an overview, we're going to be covering all these different conditions and the relevant drugs for them. But the ones that you really have to know and keep in your mind for the exams are the ones that are highlighted in purple. And that's because these are your core drugs that are listed on your ePharmacology website. So when you're going through and revising for this topic, just keep in mind that you really want to make sure that these are solid and well revised, because they're definitely things that can be asked in the exam. Okay, so when it comes to constipation, our primary aim is to evacuate that bowel obstruction. And the way that we do that is by increasing gut motility with one of two strategies or even both. So the strategies are you can increase the peristalsis of the gut, or you can soften the stool in some way and make it easier for it to be evacuated. So the ways that we can achieve this is, first of all, we have our bulk laxatives, and these are undigested polysaccharides and sugars that form a bulky mass within the gut. And as a result, this bulky mass can really push against the walls of the gut, and in that way stimulate peristalsis, which you might remember from GIT physiology. You don't have to know any core drugs here, but if you want an example of a drug, they usually end in mucil, so metamucil, citrasil are examples of bulk laxatives. But you don't have to really remember any core drugs for this one. It's more so the mechanism of action and what it generally does. Osmotic laxatives, however, are things like lactulose, and these are salts and sugars that are poorly absorbed from your gut into the body. Instead, they stick around in your gut, and because the concentration of these substances is so high within your gut, it osmotically draws out water from a lower concentration of solute to a higher concentration of solute in your gut. And in doing so, it draws water into the gut and softens and hydrates the stool, making it easier to expel. Now, there's another class of drugs called stimulant laxatives, and the example here is senna. This one is quite different to the previous two because it actually acts very actively. It stimulates the gut mucosa cells directly to increase the secretion of electrolytes and water. And again, the same effect, however, in the end, is that the water is going to soften up the stool and make it easier to expel. But a downside of active secretion and activation of the gut mucosa cells is that long-term use can result in lazy bowel. Your fecal softeners are the final drug you have to keep in mind. So that's an example of that is Docusate, the one you have to know for your exam. And the way that these work is these are surfactants. So if you remember from respiratory physiology, surfactants are chemicals that reduce surface tension. And the way they do that is they go in between the water molecules and reduce the hydrogen bonding between them. Therefore, the water is going to stick to itself less cohesively. And so the water that lines the gut walls, the water that's stuck onto the gut walls, will actually collapse into the gut and go onto the stool and actually be absorbed by the stool and soften it. So again, you're still going to have a laxative effect here, but because it relies upon the water that's stuck to the gut walls, it's going to be a weaker laxative effect. But it's more suitable for those that require less straining. So that's things like pregnant mothers and people who've just had surgery and don't want to overstrain the muscles and cause more damage in those areas. Next up, we have treatment of diarrhea. And with diarrhea, our primary aim is to actually rehydrate patients. And one of the ways that we can do that is by decreasing gut motility, so slowing down the passage of food through the gut, and therefore maximizing absorption of water from that. And the way that we achieve this is primarily by decreasing peristalsis, so decreasing the movement of the gut that pushes food out. Ways that we can do that is we have opioids available to us. So an example of that is loperamide. So opioids, if you remember, generally do cause constipation, but loperamide is more specific for the gut. The way that it works is that it acts on new receptors of the myenteric plexus. It decreases the peristalsis and secretions through this. And so the stool moves more slowly. It has more of its water absorbed, and therefore you're minimizing the loss of water and you're rehydrating the patient. So that's very effective as well. And again, you have to know loperamide as your core drug. You also have muscarinic antagonists. And again, muscarinic antagonists, they're going to inhibit the muscarinic receptors. And in doing so, they're going to inhibit parasympathetic activity. So you're going to have less of your rest and digest response. And that digest component means you're going to decrease peristalsis. Your stool moves more slowly, and a similar effect, you're going to maximize water absorption and rehydrate the person. Now, you do have some unwanted side effects from here, which is that you're going to have dry mouth, drowsiness, constipation, urinary retention, all because of the systemic effects of anti-muscarinic activity, which you would have covered back in year 1. All right, now we come to the physiology of vomiting. So the way that vomiting works physiology-wise is I like starting off with the vomiting center. So I'll get my tool up so I can point at different things. So the vomiting center is here, and that's sort of the central hub that will receive signals that stimulate vomiting. So it gets inputs from a lot of different areas. One of them is your vestibular nuclei, which gets input from your labyrinth to develop balance sense. So the labyrinth is in the ear and it helps develop your balance sense. And whenever there's anything wrong with that, so for example, in motion sickness, where the signals coming from your eyes may not match up with the vestibular signals, you might end up getting a bit of motion sickness, and that's mediated via the vestibular nuclei, sending signals to the vomiting center. You also have cells in your gut called enterochromaffin cells, and these sense toxic chemicals or toxins in the gut. And again, it makes sense from here to induce vomiting because you want to get rid of that substance in the gut as soon as possible and minimize absorption of it into your body. You also have higher cortical centers, and these are centers that are going to induce vomiting in response to, being emotionally overwhelmed, having a lot of pain, seeing something repulsive, or even smelling something really repulsive, and that's going to induce vomiting in that scenario. And then you also have what's called your chemoreceptor trigger zone, or your CTZ. An important thing to know about this is it's located in an area of the brain called the area postrema, and it will sense like other emetic stimuli or other vomit-inducing stimuli. The main one you have to know for this is chemotherapy drugs. They sort of mediate vomiting by acting on this area. And it's also more of a relay center. It passes on signals from the vestibular nuclei, the vagal afferents. So it sort of relays those signals to the vomiting center as well. All right, so that's the physiology of vomiting, or what induces vomiting. Next, we're going to talk about the actual medications or antiemetics that can be used to treat nausea and vomiting. So first up, we have our antimuscarinic drugs. Now, with antimuscarinic drugs, the classic example you're going to learn about is hyoscine. And these reduce the parasympathetic nerve activity of the gastrointestinal tract, so similar to before. And that actually keeps the sphincters closed because remember, parasympathetic is more of the rest and digest, and that would want to sort of stimulate sphincters opening. But in this case, we're going to reduce that and cause sphincters to be closed. And if you close off your sphincter, it'll mean that the vomit won't be able to eject up, right? And be spewed up. And so that's very effective in motion sickness. Now, the main things you have to know for this is that, again, it can come in two forms, an oral or skin patch. So it's kind of unique in that it can also be absorbed transdermally. So keep that in mind that you can sort of whack on a skin patch of hyoscine prophylactically if you know you have motion sickness, and that can help prevent it. But you also have your unwanted effects again of antimuscarinic systemic side effects, dry mouth, drowsiness, constipation, urinary retention, all the stuff you would have covered back in year 1, your sludge symptoms being sort of reversed. You also have your antihistamines, and antihistamine, the classic example that they give is promethazine, the one you have to know from e-pharmacology. It blocks H1 receptors in the area of postrema, so it doesn't need to cross the blood-brain barrier, but it can just go to the area postrema and block the H1 receptors there. And so it blocks an input from the vestibular system. So it's again very effective in reducing motion or morning sickness, but not as much useful in the chemo-induced nausea and vomiting, which is more centered around the CTZ. Anti-serotonin or anti-5-HT3 drugs, they're both the exact same thing. So serotonin and 5-HT3 are synonyms for the same thing. And the example of the drug you have to know for this is ondansetron. And it blocks the serotonin receptors in the chemoreceptor trigger zone. So it crosses the blood-brain barrier to do that. And it's very, very effective for chemo-induced nausea. So whenever it comes to your exams and you're having a question where a person's undergoing chemotherapy, usually the effective drug that's going to help reduce the nausea and vomiting for that is going to be ondansetron. You also have some anti-dopamine dopaminergic agents, so metoclopramide and prochlorperazine. They both block D2 receptors in the chemoreceptor trigger zone, but they also have a secondary effect peripherally of facilitating gastric emptying. So both of those things help reduce nausea and vomiting. Then you have a newer class of drug, not as important, but we'll just put added in there for your own knowledge. These are your anti-NK1s, and the example given there is aprepitant. It's a new class. It's more useful as an adjunct with other medications. It's indicated in chemo-induced motion sickness, alcohol-induced, but it also has some side effects because it reacts with your or interacts with your CYP450 enzymes. Right, so those are your antiemetics. Next, we have gastric ulcer disease and reflux. So both of these result from usually an oversecretion of hydrochloric acid. And so it's important to understand how hydrochloric acid is secreted by your parietal cells. So your parietal cells receive signals from many different chemicals. So it receives pro-stimulatory signals from gastrin, histamine, acetylcholine, and it receives inhibitory signals from somatostatin, which you would have covered again in a physiology lecture. And all of the stimulatory signals have the effect of causing preformed proton pumps to be pushed out onto the membrane surface on the luminal side. And then those pumps can help push out hydrogen ions into the stomach lumen and therefore increase the acidity. Now, you might be wondering, where is the chloride ions coming from? Well, the chloride ions, for them to be actually drawn out into the stomach, you actually have to exchange a bicarbonate ion with it. So the chloride ion is pushed out into the stomach lumen, and the bicarbonate ion is pushed back into the bloodstream. And so what that means is you actually have a bit of a rise in your pH, or what's called an alkaline tide, during and after a meal. Clinically, it's important because let's say a person is vomiting a lot. If they're vomiting a lot, they're going to be losing a lot of hydrochloric acid from their stomach. And so your parietal cells will start to compensate by pumping out a lot more HCl ions. But in doing so, they're going to have to exchange a lot of bicarb with the blood. So they're going to be pumping a lot of HCl out into the gut lumen, into the stomach lumen, but they're also going to be pumping in a lot of bicarbonate ions into the blood. And as a result, you can actually end up with something called metabolic acidosis, which is alkalosis, which is going to be, again, important when it comes to renal physiology. So we won't talk about that too much here, but just keep in mind that the mechanism for metabolic alkalosis when it comes to vomiting can be explained by that alkaline tide. In terms of medications that can be used to treat gastric ulcer disease and reflux, when treating these conditions, we want to reduce stomach acid secretion and also protect the gastric mucosa from further damage. So drugs that exist, the one that you'll commonly talk about is your proton pump inhibitors or your PPIs. And the example that's given for that is esomeprazole. So basically any drug ending in prazole is going to be a PPI. So just keep that in mind that whenever you hear a drug name and it's ending in prazole, it's a PPI. And the way that these drugs work is that they are converted into their active form when they enter the stomach's acidic pH. Then they accumulate in a region of the parietal cells called the canaliculi, and they inactivate the hydrogen potassium ATPase pumps or the proton pumps. And so they directly stop the pumping of hydrogen ions into the stomach lumen. and they do that irreversibly. So they're the most effective. And a quick note here as well is you take them 1 hour before your meal, because if you remember, we said that it was converted into its active form in the stomach's acidic pH. If you have it during or after a meal, that's when your stomach's pH is going to be even more low, because your stomach's going to secrete even more acid, and that will potentially interfere with the function of this drug. Another important thing to keep in mind is that it takes time for it to return to baseline. So when you withdraw this drug and stop taking it, it won't immediately mean that you return back to your normal acid secretion, because it takes a while for the preformed proton pumps to replace the older ones that have been irreversibly made dysfunctional by this drug. You also have your histamine antagonists, and the example that's given here is ranitidine. It blocks stimulation of the H2 receptor on parietal cells, and again, that's going to reduce HCl secretion, but it's not as effective as directly stopping the proton pumps directly, because you can still get other pro-stimulatory signals from other areas. That's why it's not as effective maybe as a PPI. You also have prostaglandin analogs, and these work more so to protect the gut mucosa. And the way they work is by increasing blood flow to the gut mucosa. And so they're especially useful when it comes to COX inhibitors, because if you remember COX inhibitors like aspirin, one of the side effects that they have is they inhibit prostaglandin production, and in doing so, reduce the protection of the gut mucosa and make it more prone to ulceration, which is why when you're using NSAIDs like aspirin, you have the risk of causing gastric ulcers. And so prostaglandins like misoprostol can help reduce that side effect. It's also not used in pregnancy because it can stimulate uterine contractions, but it is definitely also useful for nausea and vomiting. Sorry, not useful for nausea and vomiting. It can induce nausea and vomiting. You also have sucralfate, which is another medication that can be used. It becomes viscous in the stomach's acidic pH. So again, because it requires the stomach's acidic pH, take that 1 hour before your meal, because during and after the meal, it's going to be a bit too acidic for it to function, and therefore it needs to be taken before the meal. It adheres to your surface of the ulcers, because when it becomes viscous enough, it can sort of just stick to it and adhere to it and protect it from the luminal factors. So prevent further damage to that ulcer and keep it safe under that layer. All right, that sort of covers the majority of drugs you have to know for the GIT system. Just some minor points here for gastric ulcer disease and reflux. There are 2 other drugs that are mentioned in your lecture, so I'll just briefly mention them here as well. So one of them is bismuth chalate. So it's sort of a similar mechanism of action to sucralfate, in that it sort of thickens and then covers the ulcer. But the problem is that it can actually cause your stools and your tongue to blacken, which can be quite distressing for patients. And also, it has been associated long-term with toxic effects on your CNS and your kidney. That's why it's not very commonly used. But you also have a more commonly used drug, which is your antacids. And as the name suggests, it's sort of a weak base that can go into your stomach and slightly neutralize the pH. The only thing you really have to know about that is if you're using an antacid, it's harder to use a PPI or sucralfate because they require the stomach's normal acidic pH, whereas your antacid is going to try and neutralize it a little bit and bring it up, which might make those other drugs less effective. So I hope that sort of makes sense with all those different drugs and all the different things you have to know about them. If you have any questions or any concerns about anything we covered all today, let us know in the comments or send us a message. Otherwise, that's it for the pharmacology of the GIT system, and we'll see you in the next one.